What's up, everybody, and welcome to another episode of the Apogee Fitness Podcast, coming to you from the Apogee Therapy Center recording studio. My name is David Carter.
And I'm Jeff Carter.
That's right, y'all. You heard it. That's Jeff Carter, my dad. So, my dad has graciously accepted the invitation to co-host today's podcast episode. Yeah, as you guys know, a lot of our podcast episodes kind of revolve around the CrossFit world. Today's episode is going to involve a little bit of fitness, but also a little bit of life, but a lot about physical therapy and orthopedics and sports medicine, recovery, and even injury prevention. So I thought, who better to bring on to co-host today's episode than the guy who introduced me to physical therapy at a very young age.
Yeah, it's interesting. I was thinking about that, David, how I have a picture of you sitting next to one of my patients when you were about 3 years old, and I was doing an ultrasound of her shoulder. And I remember you coming in to a sports medicine facility that we had in New Jersey, and you would come in and watch the patients and interact with them. And I knew from a very small age that you were really cut out to do this. And
yeah,
so I'm pretty excited.
I was thinking about the same thing. I was thinking about, obviously I've known you my entire life. And some of my earliest memories are going to work with my dad at a young age, like he just said, 3, 4, 5 years old. And funny story real quick. I remember one of the best things I thought about my dad back then was when I got to go to work, I used to be able to play with all the wheelchairs, the crutches, jump on the beds, throw the balls at the trampoline, all that cool stuff. But my dad was able to do something that no other therapist in the clinic could do, and that was balance on the back two wheels of a wheelchair and roll it around the entire clinic like it was nothing. And so I remember as a little kid being like, I'm going to do that. So I learned how to do that probably at like 5 or 6 years old, and to this day, it's still my party trick.
That's pretty cool.
Yeah. No, so it's been great. Today's podcast, we're bringing in a local orthopedic surgeon. His name's Dr. Ian Gao. He works with CONA, Carolina Orthopedic Neurology Associates. He's heavily involved in sports medicine. Let's see here. He is from Clemson. He went to Duke University for his undergrad. Went to Northwestern for med school, did his residency at Emory, and did his fellowship at Stanford. He's worked with multiple professional athletes and college athletes, so I'm really excited to hear more about that. But yeah, we'll miss Kevin on this one. He's away doing some more photos around the world. I don't know exactly where he's at tonight, but he's taking some professional photos at some concerts. So yeah, Dad, I'm glad you're here. I am going to refer to him as Dad throughout the podcast. So if you catch this in the middle of the podcast, don't think it's weird. Because I feel like if I say Jeff, I'll just be stumbling over my words the entire time. But yeah, grateful for you to be here, Dad. Ian, what's up, man? Thanks for coming on.
Thanks for having me. Good to be here.
Yeah, dude. So how's your day going so far?
It's been good so far. Looking forward to doing this podcast with you this evening.
Absolutely. So is this your first podcast interview?
This is actually. So thanks for kind of breaking the podcast cherry.
There you go. Yeah, Kevin's usually here to make that awkward cherry noise, but no, it's good, man. I'm glad you're here. So before we get into all things orthopedics and like physical therapy and rehab and fitness, tell us a little bit about your upbringing. I said you were from Clemson, but talk a little bit about growing up there, your family life, and if you played any sports back then.
Sure. I was actually born in China, and I have a twin brother, and then my parents, and we moved to the United States when we were really young. So I grew up in Clemson since I was 6 years old.
Oh, wow.
And then growing up, I don't think there was anything too abnormal about my life, but my parents, kind of instilled in me a good, strong work ethic, and worked hard during school, but also enjoyed hanging out with friends and playing sports. And so I, growing up, I played Little League baseball, dabbled in a little bit of soccer, but wasn't too good at it, so stopped doing that, and then played rec league basketball. And so I had always enjoyed playing sports growing up.
All right, cool. Go for it, Dad.
So did you have a pretty well-balanced childhood? What I mean by that is You talked about sports. Did you get into music? Were you into science? Obviously, becoming a doctor. At what point did you really realize that that's the direction you wanted to go in?
Yeah, I did grow up also with music, so I did grow up playing piano, and then also I played trumpet growing up too. And so I
Okay.
actually played trumpet starting in middle school through high school and even through college. And then after that, didn't have as much time, so I haven't really stayed up with it. But and then throughout school, I was obviously interested in kind of science stuff since that's how I became a doctor and physician. But um, in terms of figuring out when I wanted to be a physician, I don't know exactly when there was a time point, but I think even in elementary school, I was somehow thinking of wanting to be a doctor and specifically a surgeon, because there was actually in elementary school, they made us all write in this little book what we wanted to be when we grew up. And a lot of people would, some of my friends put, oh, they wanted to be an astronaut. One person was going to be an NFL player and then an NBA player. And then for some reason I put, I'm going to be a surgeon living in LA. But
That's awesome.
not living in LA, which is perfectly fine with me. But I did end up becoming a surgeon.
That's cool. So I want to take it back a little bit. So you said you guys moved to the States when you were 6.
Hmm.
Do you remember much of China, or what was that transition like coming from China to here? And did you speak any English before moving
Yeah.
here?
So I actually skipped a part where we moved to Canada first when I was 1 from China. So
Oh,
I
okay.
really was only
Sure.
1 year old when we moved away from China. And so my extended family all is pretty much still in China, but my parents and my brother are here in the States. And so we were in Canada for about 5 years and then moved to Clemson, South Carolina
Gotcha.
when
So
I
were
was
your
6.
were your parents fluent in English prior to
They
moving to
were
Canada?
not fluent at all in English. They learned English by themselves after they moved to Canada, just on their own with either. I think my mom actually learned a lot of English watching soap operas, and then
Ah,
my dad. Well, the reason we moved to Canada was because he was doing his master's and PhD in mathematics.
Hmm.
And so he, I think, had some more kind of formal training in some English, but mostly they just learned it both on their own.
Yeah, it's interesting. We've had at least 2 foreigners, on the podcast, and both of them have said that one of the major ways they learned English was by playing video games. Because most video games, wherever you are around the world, there's only 2 languages that are on video games for the most part: English and Japanese. So you're either
That's
playing video
yeah.
games in English or you're playing them in Japanese, which I thought was very interesting.
Yeah, luckily for me, I grew up pretty much as with English as my first language, and
Sure.
so I played video games already learning English.
Yeah, no, that's great. All right.
so, so as a Canadian, do you say A?
I don't, but my wife is actually Canadian, and she still says it, so I'll
That's
make fun of her for that.
There you go. Hey, I have a question for you. One of the things we're a teaching institution, so we get physical therapy students in quite a bit, undergrad, and we've had grad students and physical therapy assistant students. And one of the things I talk to them about is the importance of being able to use your hands. Obviously, as physical therapists, that's what we do. We use our hands quite a bit. As a surgeon, clearly you have to use your hands very as well as your mind. And so did you do anything as you were growing up? Did you like to do artwork, or did you go into the garage and take things apart and put them back together that helped you learn how to use your hands?
I think probably the thing that helped me the most in terms of hand-eye coordination was actually, growing up playing piano and trumpet, and then also playing sports with, uh, baseball and basketball mostly. But not to say that that was the sole contributor to my hand-eye coordination, but I think that definitely helped. And um, I wasn't really a kid growing up that liked to really take things apart, put them back together, except for maybe Legos.
Mhm.
But yeah, I think probably music and sports were probably the thing that helped the most with my hand-eye coordination.
So when you say you played trumpet, were you playing trumpet in the band, or were you playing like jazz trumpet?
I played both actually, and so I played in kind of the regular band and also in jazz band, and then luckily I was able to actually get pretty good at it, and so I was able to play in the Duke University Jazz Ensemble when I was there in college.
That's awesome.
That's great.
So
Yeah.
we are super big jazz nerds, my dad and I. I pretty much was brought up on jazz music. So we whenever we get together, we throw it on.
Any favorite artists?
We like Foreplay. We like the Rippingtons. We like
Boney
Boney James. Yep. So more smooth jazz type
Yeah.
stuff. But that's cool. Yeah, I grew up playing instruments as well, so it is interesting to see the correlation between learning something like a musical instrument and then the brain pathways it takes to kind of. I kind of thrived in the sciences myself, so and a lot of my friends, they played instruments as well. So I think it definitely helps. So going into med school, was orthopedics always, you said you wanted to be a surgeon, but was it
Right.
always orthopedic surgery that you wanted to do, or was that kind of a pathway you chose throughout med school?
Yeah, so in med school, like you had mentioned, I knew I wanted to do surgery. I didn't know specifically which surgical subspecialty yet. I think, always kind of leaning towards orthopedics because during my undergraduate studies, I did biomedical engineering, which is kind of related to, biomechanics and is pretty similar to orthopedics in terms of the thought process and kind of the principles. But during med school, I tried to just get involved with and get as much experience with all the different surgical subspecialties. And I think when it came down to it, orthopedics was just what I was most interested in and had the most passion for, and was most similar to just my interests growing up with sports. And also I liked that with orthopedics, if basically something was broken or something's torn, and it's something that you can fix,
Right.
and then people get better from it. So
Right.
I liked having the tangible results from it.
Very cool. So Northwestern for med school, was that at the top of your list?
It was, yeah. It was a great med school, and it's in a great city of Chicago, and I had a great 4 years there. It was definitely a lot of studying, but it was a great place to be for 4 years.
That's awesome. So my dad here, he grew up in Chicago.
Okay.
So,
That's
Yeah, so I'm sure he can tell you about Chicago as well. And the winters were definitely brutal, but the summers were, I think, probably one of the best cities to be in the summer.
for sure. I
Cubs,
remember.
Cubs or White Sox.
I would say Cubs.
Oh yeah,
but-
you can't beat an afternoon in Wrigleyville.
Yeah.
You can't. I remember, Dad. When was this? This would have been. Was it like 95, 96 when Northwestern went to the Rose Bowl? I
I
believe.
can't remember.
It was
Somewhere around
definitely
there.
in the mid 90s.
Yeah,
And one of your coworkers' sons played on that team.
that's
And
right.
I remember him. I was at work that day with you, and he must have been on winter break or spring break or something, because he was at work with his mom as a college student. And I remember up until that point, my only experience with athletes were maybe high school athletes. I was very young at this point, probably like 10 years old. And I remember seeing this guy and thinking he was the largest man I had ever seen in my entire life.
It was really funny watching you because not only was her son from Northwestern there, but her son who went to Clemson was there as well. And David looked up at these two giants, and you should have seen the look in his eyes. It was amazing.
Yeah, I distinctly remember that. But cool, man. So talk a little bit about, med school, going into orthopedics, and then finally getting into your residency.
Yeah, I mean, during medical school, the first 2 years are all basically just kind of book studying, and actually you don't really see that many patients. It's mostly like college all over again, but crammed into 2 years.
Mm-hmm.
So that wasn't the most fun 2 years, but in the third and fourth years of medical school is when you start kind of working in the hospital and seeing patients and seeing the operating room and kind of getting that experience. And so that's when I was able to do all of the experience in orthopedics. And during the fourth year of medical school is when you have a little bit more freedom of kind of doing what's called rotations, or 1 to 2 to 3 month time blocks of in a specialty that you're interested in. So I had spent pretty much all of that doing rotations in orthopedics, and we actually got to travel to different other academic institutions throughout the country to do 1 month of orthopedics at another at different academic institutions, and then I actually got to go to Germany for 1 month as a kind of my final. Actually, that was my last 1 month of medical school was in Berlin, Germany.
Wow, that's cool. That's a party.
Yeah. It was, we'd learned some, but definitely had some fun too.
Yeah, definitely.
So would you say that there was one or two people in your life when you were in med school and then doing your residency who was your mentor? You said, this is the person that taught me a lot. I want to be like this person. Show me everything you can because I really think you have it together.
Yeah, actually in residency is when I think I had a really good mentor who really taught me a lot and was pretty much the type of kind of orthopedic surgeon that I was trying to aspire to be. His name, everybody actually calls him Dr. X because his last name is a Greek last name that nobody can pronounce, and it starts with an X, so everybody just calls him X. But he is a sports medicine orthopedic surgeon during my residency at Emory, and he actually is probably one of the most well-known ACL surgeons in the country, and so I got to learn a lot from him about that, and that's now become one of my specialties. And he just the way he interacted with patients, and then also his kind of surgical techniques and the way he did things was something that really was something that I was aspiring to be.
All right, so going from Emory, or I guess from Northwestern to Emory, big change. You're back down south.
Yeah, back to warm weather and no more negative 20-degree winters.
So it was a pretty easy transition in that field part of it, I'm sure.
Right.
All right, and then you land this awesome fellowship in Stanford. Talk about that.
Yeah, I was really excited and lucky to be able to do what's called a fellowship, or basically an additional year of subspecialty training in sports medicine at Stanford. So I was out in Palo Alto, California for a year, and during that time period, I was just able to specifically focus on training and doing more with sports medicine type procedures, which are a lot of shoulder and knee surgeries and what's called arthroscopy, meaning minimally invasive shoulder and knee surgeries. So things like ACL surgeries, meniscus surgeries, knee ligament surgeries, and shoulder surgeries, rotator cuff surgeries, labral tear surgeries. And so that was the kind of surgical training aspect of that, but also there was a lot of being able to work with a bunch of the professional, collegiate, and high school teams in the area. That was, I think, really valuable. We were able to gain experience with working with professional athletes from the San Francisco 49ers and the Oakland Athletics, and I was helping out with the Oakland Athletics Major League Baseball team and did their spring training with them and saw their athletes and helped treat them. And then I was actually, for one of the local community colleges in the area, I was their kind of head team physician for the entire year, taking care of their athletics and making sure that there weren't any issues with their athletes and treating them. And then we would also help out with some of the high school teams as well. So athletes from all different levels and all different ages.
Wow.
At what point do you feel that you really started feeling in the groove? I mean, when you're starting to do your first surgery, you're thinking, I'm sure your heart's beating a little faster, the sweat's dripping a little bit. And then after you've done it and the patient survived and actually did really well.
That's always good, yeah.
That's always a good thing. When did you feel that you really had the confidence to move forward and just take it to the next level?
Yeah, I think, like you mentioned, during residency and fellowship, you're always, there's always somebody there to kind of back you up, and really, you don't have that much of the actual personal responsibility. But once you're out in practice on your own, then it's just all you. And there was definitely the butt was clenched a lot tighter during the first few surgeries. And you know that you're well trained and that you know what to do, but it's just, I think, there is a mental component of knowing that there's nobody else there to help you out or back you up, and you're the one there to do everything and make all the decisions, even though you know what to do and you know that you can do it. And to be honest, I think it takes several months, even up to 6 months after you start, to really get into the groove of things and feel comfortable with everything. And even after that, you're still continually learning and getting better. And so I don't know if I can say that I'll honestly be, comfortable just, not, or comfortable and not having to worry about anything. And I don't think anybody should be just comfortable and not worrying about anything, or else they become complacent and they might make mistakes or do the wrong thing. And so I think it's always good to just be a little bit on your toes.
So what was
Absolutely.
yeah, 100%. So what was it like, when you were doing those first surgeries by yourself and you have all these people underneath you that you're kind of directing, hey, give me this, do this. Was that kind of hard?
It's definitely a change, because during training, you're the one that somebody else above you is telling you what to do, and now you're the one in charge. And so it was definitely a little bit of a change, but having been at the bottom of the totem pole and now kind of climbing up that ladder and knowing where you came from, I don't treat anybody differently, and I think it's extremely important to kind of know that everybody's there kind of as a team to help out and kind of doing their job to get everything done correctly.
Yeah, absolutely. I have a question real quick. So this is interesting to me. You worked with professional athletes who this is their livelihood. They make millions of dollars is on the line for them. And then you're also working with high school athletes who some of them probably won't even play past high school. Was there a little bit more of a pressure performing surgery on some of these professional athletes as opposed to some of these high school athletes?
To be honest, I think there was a lot more pressure. Not to say nothing was done differently.
Right,
everybody
yeah.
got the same treatment.
Of course.
But of course, there's going to be a lot more pressure when somebody's livelihood and it depends on it. And luckily for me, like I said, at that time, I am not out there on my own. You have somebody helping you out.
Mm-hmm.
But I think you definitely know that in the back of your head that there you feel a little bit more of that pressure. But that's what you've been training for, and that's what you've done so many years to get good at. And so the training kind of kicks in, and I think that pressure actually helps to make you perform better, and kind of, like I said, kind of keeps you on your toes and making you sure that you're thinking at all aspects of what you're doing, and not just suddenly forgetting to do something. But again, like I said, everybody, no matter what level of athlete, they're not getting any type of special treatment. But yeah, you do feel a little bit of that pressure.
Sure.
There's a lot of people who are listening to this podcast from different countries around the country, around the United States and different countries. And there are a lot of people from a variety of different backgrounds and pursuits. What can you tell them, someone who's trying to be a doctor, someone who wants to be a therapist, a dietitian, or a CrossFit athlete who's working their way up and trying to make it to the CrossFit Games? What you've gone through is like going through training as an athlete, because it's very physical, it's very mental, it's very demanding. You have to put your heart and soul into it. So what would you say to these athletes or other people, undergrads who are maybe wanting to be a doctor, to encourage them to move forward and just to keep their eye on the ball, if you will, and just keep going? What kind of words of advice would you give them?
Yeah, that's a great question. I think number one, you have to have the drive and the strong work ethic, first you have to want to actually do it. You kind of have to ask yourself, is this something that I actually want to do? Because this is going to take many, many years of your life, whether it's CrossFit training or, training for to become a doctor or a surgeon. You have to really want it first. And then if you do know that you really want it, then you'll have the drive and the passion for it. And so then it's just a matter of, I think, kind of keeping that strong work ethic. And then it's, I think, really important to have a mentor who that you are able to, number one, look up to and aspire to kind of emulate, and then also have them to be able to help you along the way. I don't think anybody has been able to, or not, maybe not anybody, but not many people have been able to get to, these types of positions without help. And so I think it's really important that early on to see who is somebody that you're aspiring to be, and if you're able to have them as your mentor and ask them questions, ask them what they did, and have them to help you out, because you're not going to be able to do it on your own. And then finally, number 3, I know, obviously people have this goal in mind and they're working really hard at it, but also I think it's really important to remember to take a break sometimes and not have that as the only focus of your life, and to be able to take a break from it, and to be able to kind of have some type of outlet where you're doing something else so that you don't get burned out.
Absolutely. That's excellent. I really appreciate you saying that, because quite frankly, there are a lot of people in here who are listening to this who are they're feeling a little bit edgy right now. Can I make it? Can I do this? And having you say that to them is really, really encouraging. And also what you're doing, as that the fact that you have made it in your profession, and you had stated that you're always learning, you're always moving forward, but the fact that you are in the position that you're in, and that you're giving forward to the next generation, if you will, is really, really encouraging to everyone in the audience. And what I would encourage anybody who's listening to this, when you have arrived, when you have made it, I would encourage you to do what the doctor's doing right now, is to give forward to the future, because that's what it's all about. If we can help other people achieve what we've achieved, even if it's in a different occupation, that's really, really important.
For sure. I 100% agree. I think one of the biggest vices is complacency, like you said. So if you become complacent in any aspect of life, you'll never grow. And if you're not growing, you're dying, right? So
Correct.
I remember being, obviously there's going to be a lot of things that I say I remember growing up because I'm talking with my dad. But one of the biggest things he taught me growing up is never settle for mediocrity, right? So we're always learning, we're always improving, we're always trying to further ourselves. And I think just by aspiring to do that, you bless others when they see you do it as well. So
Absolutely.
Cool, man. Let's move on to current practice. So you are back home. You're in the upstate area. You're in Greenville, Spartanburg area. You landed with Carolina Orthopedic Neurology Associates. So talk about Kona. Talk about how you got involved with them and a little bit about that practice.
Yeah, so during my last year of training, which was the fellowship year when I was out at Stanford, that's when I started looking for, a job and where I was going to work for, and start my practice. And, during my job search, I looked at pretty much throughout the entire country, East Coast, West Coast, Midwest, and I had interviewed at a bunch of different job group practices around the country. And then this group, Kona, here in the upstate of South Carolina, really just stood out to me. Well, number one, I'm from the area, so it was nice to be back in the area close to family. But the group itself, is a private practice, which is something that I wanted to do. In terms of being in private practice, I wanted to be able to kind of be my own boss and be able to do what I wanted to do in terms of my medical practice and set my own schedule, see the patients that were the ones that were towards the specialty that I was interested in terms of sports medicine, And so Kona was actually, I think, the biggest private practice in the upstate area. And then the people in the group that I met when I came down to interview were just, I think, the best group of people that I had talked with and interviewed with. And I think it's really important that whatever group you're a part of, and you're going to be spending many, many years with these people, that they're good people, that you get along with them, and that they were very well respected in the community. They did, had patients had very good things to say about them. They had a very good reputation in the community, and if you actually, looked at all the reviews on whatever websites you want to about all the different groups in the area, Kona was vastly and by far had the best reviews from patients in the entire area. So that was a group that I just wanted to be a part of, and to be able to build on that, and to have good partners to work with, and have be a part of the community that people had a good good things to say about.
Yeah, for sure.
Well, I'm up here in Grand Rapids, Michigan, and I had not ever heard of your group until David had told me about you guys. And so I went on your website and I took a look, and you're pretty diverse in your team there. You treat lots of different types of injuries there. And so, did you find it really refreshing coming into a group that there's a diversity in age, there's a diversity in skill set, expertise? Do you guys work really well together and complement each other?
Right. I think that's a great point. The diversity not only in the people that are in the group, but in terms of our specialties. And so, we pretty much, our group covers any musculoskeletal problem that you can think of from head to toe. I deal mostly in sports medicine. Mostly I see shoulder and knee injuries, sometimes elbow and hip stuff as well. But we have spine surgeons and neurosurgery in our group who deal with the back issues. We have hand surgeons and then also foot and ankle surgeons. And so pretty much we have everything covered. And so if it's something that I see in the office, a patient has an issue, but it's not really my specialty, or something that I think somebody could take better care of, then I can just send it to one of my partners in the group who would probably be much better than me at it, and can get the patient the best care possible.
Yeah, that's happened a few times since I've met Ian. I've been able to text him and said, hey, I have this patient. I think they're kind of past this physical therapy. I think that they really need to get in to see a physician. Possibly surgery is in the future. And yeah, that's happened a couple times where I've texted him and he said, well, that's not really my specialty, but let's go see my friend doctor so-and-so, and been able to get them in very quickly, which has been really awesome.
That's great. When I was looking at the website last night, I looked at your partners too, but I was looking at you, and you had these educational videos on the total shoulder, on ACL. And I've been a physical therapist for 36 years. And so I understand these things, but someone who comes in who wants to know a little bit about the surgery, the procedure that they're going to be receiving, I thought you did an amazing job in really explaining what you're going to do, how the mechanics, why pick one shoulder replacement over the other shoulder replacement. I thought you did an excellent job, and I applaud you on that.
Well, thank you very much. I appreciate it. I think one of the reasons that I try to explain it in as easy to understand terms as possible is because when I was younger, going to see doctors, they would use medical terminology and jargon that I didn't really understand, so that was frustrating. But also, if my parents or my friends that would see the doctor, and they would also complain about how the doctor just was not easy to understand in terms of what they were trying to explain, or they used too complex medical terminology. So I really tried to avoid using complex medical terminology and try to explain it as if this was a friend getting the procedure and telling them this is kind of what's going to be done, and try to explain it in non-medical terminology.
Yeah, absolutely. I feel like that's when you get the best results too. If people understand what the goal is, what's trying to be accomplished with the procedure. And we find that in rehab too, when the person really understands what happened when they had surgery and where we're trying to go with rehab, and understand like the mechanics of the joint that we're working on and how the rest of the body relates to that specific joint. It just makes rehab so much more smoother, because they understand, all right, this is why I'm doing this, this is why I'm doing this, and this is the goal we're trying to achieve by doing all of these things. So I think by having a surgeon that prior to surgery definitely describes exactly what's going on and what to expect after surgery, that's huge. I find that a lot, and I'm not bashing anybody, but I do find that, from different groups, that when I could count, if I had a dollar for every patient that said I had no idea what this was going to be like after surgery, I would have a second income, right? I don't think that a lot of providers do a really great job of kind of explaining what to expect and all the work that's going to have to go into rehabilitation after surgery to make this a successful surgery, right?
Yeah, I completely agree with that. And so one of my goals is that, if any time a patient of mine that is being scheduled for surgery, I try to educate them beforehand on exactly what you were saying, the type of recovery it's going to be like afterwards. Because once the surgery's done, that's not it. The hard work is about to come for the patient to work with physical therapy, because oftentimes, especially with orthopedic surgeries, there's a significant amount of physical therapy and rehab involved afterwards. And so I always try to educate the patients before surgery to let them know, what a typical timeline of recovery would be like, in terms of what they would be doing kind of week to week or month to month after surgery. And that's just a general timeline, but I think it gives an idea for a lot of patients to know how much of a recovery is involved after the surgery, and to know that it is extremely important to work with somebody like you, David,
Mm-hmm.
and Jeff, in terms of physical therapy to get better after the surgery.
Hey guys, we're going to take a break to thank our sponsors for today's episode. We're going to start off with CrossFit Greer. If you're living in the Greer area and are interested in getting started in CrossFit, go ahead and look up CrossFit Greer. Jen and Reagan Green are the owners there. If you mention the Apogee podcast to them, they will give you 10% off your first month's membership fees.
I would also like to thank Blitz Belts and Chris Kane for their continued support of the show. So be sure to use their 15% off coupon code at checkout. That's Apogee, all caps. That gets you, the listener, 15% off at checkout at Blitz Belts on your custom order. I want to thank GoTape for being our new sponsor. GoTape has committed its brand to providing the best in athletic tape. They are the standard for CrossFit tape, Scary Sticky. Now they are providing the best in KT tape. So at checkout, be sure to get your 25% off your wholesale purchase. Use the coupon code APOGEE at checkout.
Finally, if you guys would like to become an invested friend of the show and are interested in supporting the show directly, go to anchor.fm/Apogee Podcast and click on the support tab. We love bringing you guys awesome content each week, so be sure to subscribe to the podcast, drop a review, and let us know how we're doing.
I want to expand on this question for you. Like I said, I've been doing this a really, really long time, and sometimes patients who have seen people who have had similar procedures, maybe their parents or friends who are older, and they're a bit scared because of the outcomes that they had years ago. I've seen significant changes in orthopedic procedures and outcomes over the years. And what procedures have made the greatest leaps as a result of an advancing technology over the past 10 years? And what rates of recovery and outcomes have improved because of this?
Yeah, I think, I don't know what might be the greatest in terms of advancement, but I will tell you that there have been significant advancements for what's called arthroscopic surgery, or minimally invasive surgery. That's what most people refer to as like a shoulder scope or a knee scope. And that's where we use small little cameras and small instruments to go into a joint. Most of the time it's either a shoulder or a knee to, for example, fix what's called a rotator cuff tear, which pretty much all rotator cuff tears can now be fixed with 3 little small poke holes around the shoulder, and using small instruments and small camera to do that. and then another example would be like an ACL reconstruction surgery. I think has had significant advancements in the last 10 to 20 years in terms of also being much more minimally invasive, but also having actually better surgical techniques and surgical implants that provide better outcomes. And so patients and athletes and are doing a lot better and getting back to sports a lot quicker and at a much higher return rate than before because of these advancements in surgical technique, implants that we use, and just the minimally invasive nature of it. And then obviously, of course, working with you guys in physical therapy.
Yeah, I want to touch on both of those things that you just said, rotator cuffs and ACLs, right? So in the fitness and the sports world, like you said, those are probably the two most common things that get torn, rotator cuffs, ACLs. I don't think that a lot of people understand what an ACL is or even what a rotator cuff is. When I talk to people about rotator cuffs, I would say the vast majority of people don't realize it's made up of several muscles, not just one, right? And it's not a cup, right? But it is a bunch of muscles that help rotate the shoulder and lift the arm over the head. It's funny that you brought that up as one of the advancements because I remember doing a rotation in physical therapy school for 12 weeks down in Georgia, and I was at an outpatient clinic, and I swear, like maybe this orthopedic surgeon was trying to pay off a kid's college or something, because we were seeing at least 5 post-op rotator cuff surgeries from this guy a week. I mean, it was a lot. He was just busting them out, but all of them were old school with the incision right down the anterior part of the shoulder, and these patients were in physical therapy forever. And now I don't think within the last 5 years, I have not seen one other than an arthroscopic, and patients are progressing a lot quicker. So talk a little bit about what the rotator cuff is exactly, because I know a lot of people, especially CrossFitters that are listening to this, that's always a concern because we're doing a lot of Olympic lifts like snatches. We are doing a lot of gymnastics like muscle ups. So a rotator cuff is always something that everybody has in the back of their mind. So talk about what it is and the indications of when surgery would be indicated or when something more conservative like physical therapy would be indicated.
Yeah, so the rotator cuff, like you mentioned, is not actually just one muscle. It's a group of muscles. It's a group of 4 muscles, actually. And these 4 muscles are around the shoulder joint and help to stabilize the shoulder and also to provide motion to the shoulder. In order for you to lift your arm up and out and away, you're using your rotator cuff muscles. There's one big one in the front of the shoulder, there's 2 in the back of the shoulder, and then there's one up top on the top of the shoulder. And the main rotator cuff muscle and tendon that is the one that either gets injured or damaged is the one on top called the supraspinatus rotator cuff muscle and tendon. And that's the main one people use to help with kind of lifting the arm up. And that's the main one athletes and CrossFitters are going to be using for any type of, lifting above the head. And so it's very common to see injuries to the rotator cuff. I would say, luckily, the most common injury to the rotator cuff is just kind of some irritation, inflammation, and strain of the rotator cuff. And so that means there's not a tear, but it's just really irritated, painful, and weak. And the good news is that probably 80 to 90% of the patients that I see that have rotator cuff issues can be treated very well without surgery because it's mostly just pain, irritation, and weakness of the rotator cuff, which gets better with a good course of physical therapy. And most of the time, the physical therapy does the trick, but occasionally, if they're still having issues with physical therapy, then cortisone injection into the shoulder can provide good pain relief. And like I said, 80 to 90% of people do better with that. But in about 10 to 20% of people who are still having issues, that's when we talk about getting an MRI of the shoulder, which is a type of imaging that allows us to see the rotator cuff and see if there's a tear, because sometimes if there's a tear of the rotator cuff, that's when you talk about surgery to fix it.
Mm-hmm. Sorry, Dad, you were going to say something?
Yeah, I was going to say that one of the nice things about CrossFit, there's many nice things about CrossFit, but one of the nice things about it is it's functional training. And a lot of times, traditional exercise in the gym, people are doing straight plane exercises and they're never working the rotator cuff. They're never working a stability, then mobility and functional training in the process. Do you find that when you're dealing with these athletes, or whether they're high level athletes or recreational athletes or kids in high school who get these injuries, do you find a consistency with those who are training more functionally do better than those who don't understand that concept?
Yeah, so it's a funny thing, you would expect these high level athletes to be strong everywhere, right? But they're a lot of times only training specific to their sport. And so oftentimes they're only strong in certain areas and then weak in other areas. And so, for example, I saw a high level baseball player this past week who was a pitcher, and you'd expect him to have a pretty strong arm, but he pitches and that's all he does. He doesn't really do the functional, rehabilitation and functional strengthening of some of the other things that, including the rotator cuff. And so, because he wasn't really strengthening and working on the rotator cuff, he was having pretty significant issues with his shoulder and pain, and couldn't really pitch the way he wanted to. And so I actually just kind of shut him down from pitching for a few weeks and actually got him in to see a physical therapist to specifically work on his rotator cuff, because when I had examined him in the office, his rotator cuff was extremely weak, and that's not something that I shouldn't be able to, for a high-level athlete like him, be able to kind of break his rotator cuff strength. But I was able to do it very easily, which was surprising, for such a high athlete. And so he did work with the physical therapist specifically on, his rotator cuff for the next 4 to 6 weeks, and he felt great afterwards and got back to pitching and no issues. So, I think it's extremely important to, obviously, whatever athlete is going to be doing their sport-specific training, but also to be able to be aware of the other muscle groups that need to be targeted as well to avoid overuse type injury, or, having weakness of that can cause injury.
Yeah, I 100% agree. I frequently see it, even in CrossFit athletes. I see it. In CrossFit is big functional movements, and they are just that. Like, they're big ballistic movements with explosion. You're not really isolating muscles. I think we're finding now that just doing CrossFit isn't good enough, and you're going to be more prone to injury by just doing CrossFit. You have to do the accessory stuff as well. You got to do the isometric things. You need to do the isolation things. You need to do really work on the mobility things. It's funny, I'll get patients in here with excessive knee pain, and the difference between their quad strength and their hamstring strength is just vastly different. And, these are people who can deadlift 300, 400 pounds or squat, quite a bit as well, but they're focusing so much on one muscle group to move that weight, and they don't even realize that they're doing it because they're so used to doing it every single day like that. So just retraining the muscle groups to fire differently, and making the counter muscles a little bit stronger, the hamstrings as strong as the quads, can relieve a lot of knee pain.
And I agree with that. I mean, there are a lot of athletes who live in the plane that they're working in. And if they're deadlifting, they're deadlifting in a specific plane. And they don't understand that stability from the hip rotators and from the shoulder rotators are essential to prevent injury and to get excellent outcomes in their sport. And I've seen this over and over and over the years, where these people, their hip rotators are incredibly weak. They can be fast runners, but now put them on a diagonal, put them in a rotation, a pivot, they're really, really hurting. And so it's really, really important that you understand that. And quite frankly, I'm really impressed by your answer, because I've met a lot of surgeons that I don't really think understand the importance of that functional stability training of the rotator cuff. They can repair them, but to be able to instruct their athletes and or non-athletes of the importance of strengthening that is crucial. And so again, I applaud you on that.
Yeah, I 100% agree. It's a common thing that, somebody can move. We mostly move forward and backward. We don't move side to side very often. So flexion, extension, great. Abduction, adduction, not so good.
Yeah.
And rotation even worse.
Right.
Right.
Internal,
Yep.
external rotation even worse. So that's interesting. All right, let's hit ACL. So ACLs is another thing that we see often in athletes being torn. So again, talk about a little bit about how the knee joint is made up, specifically with the ACL and PCL and how they work together, and why the ACL tears so often in athletes.
So in the knee, there's 4 main ligaments. There's one on the inside called the MCL, and there's one on the outside called the LCL. Those provide stability to the knee kind of in a side-to-side motion. And then there's 2 ligaments on the inside of the knee. The one in the front is called the ACL, and the one in the back is called the PCL. And those provide front-to-back stability of the knee, but also rotational stability of the knee. And so the most commonly torn ligament in the knee is the ACL, and the most common way to tear it is from a twisting kind of pivot type injury to the knee. And unfortunately, when the ACL tears, it does not heal on its own. And so for the vast majority of ACL tears that I see in these, most of them are athletes, whether they're young or old, or just somebody that wants to stay active. And when they don't have their ACL working properly, they don't have rotational stability of the knee. And when that happens, when they're trying to do any type of rotational movement or pivoting movement or just any type of lateral shifting movement, then they feel significant instability of the knee and they can't do that activity, or they even have a instability event that could cause potential damage within the knee. And so unfortunately, for most of the people that I see with an ACL tear, we usually recommend surgery and do what's called an ACL reconstruction.
And what goes into that? So what do you usually use? An allograft, autograft? What do those things mean?
Yeah, great question. So in terms of doing an ACL reconstruction surgery, there's a lot of options in terms of where do you get the new ACL from. So like we said before, the ACL tear doesn't heal on its own. So you have to actually remove the torn ACL, and then you got to give the patient a brand new ACL. And there's 2 main options to choose from. There's what's called autograft, meaning taking the patient's own tissue, or allograft, which means taking cadaver tissue. Which a cadaver is a dead person, but it's like a transplanted tissue. And there have been a lot of different studies on which graft is better, and kind of the general consensus these days is that when you look at the data on ACL reconstruction with autograft or allograft in patients about the age 35 or older, there's really no difference in outcomes with autograft versus allograft. And so usually for the patients in that age group, I typically recommend using the allograft or the cadaver graft because, number one, we don't have to take tissue from somewhere else in their body, so there's less pain from that, and number two, they're able to kind of recover quicker in terms of being up and moving on it faster. But for the younger athletes that I see, younger than the age of 30 to 35, most studies have shown significantly better outcomes with autograft or using patient's own tissue in terms of a much lower re-tear rate. And so in those patients, I recommend autograft. And then when you talk about autograft or taking the patient's own tissue, there's several options of where do you take that tissue from. And these days, the 3 main options of where to take the tissue from is number one, the hamstring tendons, which is what a lot of surgeons use. And the hamstring tendons, you have 3 main hamstring tendons in the back of your leg, and with using the hamstring tendon graft, you're actually taking away one of those tendons, and that tendon, in addition to another small tendon that's taken, becomes your new ACL. So that's one option. Second option is what's called bone patellar tendon bone graft, and that means actually taking a small chunk of bone out of the kneecap or the patella, and then a small portion of the patella tendon, and then a small portion of bone at the tibia. And that's one way to get a graft as well. And then the third option, which is actually what I prefer using and what I have done on almost all of my patients, is actually what's called the quadriceps tendon, which is the tendon above the kneecap. And what I will tell you is between these three different autograft or patient's own tissues options, the good news is that there's no significant difference in major outcomes. So there's no difference in the re-tear rates, and there's no difference in the return to sports and activity rates. The main differences are in some of the side effects of taking the graft from a specific body part. So, for example, taking the hamstring graft, you're taking away one out of three of the hamstring muscles and tendons, and so theoretically, and actually it's been shown in studies that there can be some hamstring weakness after doing a hamstring graft for an ACL, and the hamstring is actually one of the main ACL stabilizers, and so theoretically, I don't like getting rid of one of the ACL stabilizers. The bone patellar tendon bone graft is used by a lot of surgeons and is used in a lot of professional athletes because a lot of people theoretically like having bone healing to bone rather than tendon healing to bone. It's, obviously it does show good outcomes, but one of the main side effects of that is that, number one, it is a much bigger incision and surgery on the knee, and so patients have a significantly more amount of pain after it initially in the postoperative period. But also a lot of patients have continued kind of frontal knee pain, especially with kneeling, and so a lot of patients are really not able to kneel on that knee again. And then finally, the third option, like I said, the one that I prefer using is the quadriceps tendon. So the quadriceps tendon is a big tendon above the kneecap, and the good thing is when you're using a quadriceps tendon, you're just taking a small portion of the middle of it, and it's a big, thick graft, and it reliably is always a big, thick graft. You never have to worry about the graft being too small, and it has similar outcomes to the other ones in terms of the re-tear rates and return to sports rates, but you don't get any of the hamstring weakness. And actually studies have shown, because the quadriceps tendon is one big, large tendon, and after you take the graft, you repair the tendon back, there's no significant quadriceps weakness, and there's none of the frontal knee pain that you have from a bone patellar tendon bone graft. And so because it has the same outcomes and some less side effects, I prefer using that graft.
Do you see, I think that's super interesting, do you see a difference in range of motion outcomes as far as where you take the
That's a great question too. So the good news also is that there are no differences in range of motion between all three grafts.
Okay.
How important do you think getting that patient into physical therapy at an appropriate time, and what is that appropriate time? Do you feel like it's a week, 2 weeks, 3 weeks? When do you want these patients in physical therapy, and what do you want to see from the physical therapist when you have them referred to that clinic?
Yeah, so I think physical therapy is actually the most important thing after the surgery. The surgery itself, is any sports medicine orthopedic surgeon could potentially do this surgery, but the therapy and the patient's work afterwards, in addition with the physical therapist work afterwards, I think is what gives them the best outcome. And so my preference is that they start working with physical therapy actually as soon as possible, within a few days after surgery, to start getting their knee. The first thing that is most important for them to get back is their motion, because after any type of knee surgery, the knee gets swollen, it tries to get stiff, and so to prevent the swelling and the stiffness, they got to get their motion back. And so it's extremely important, I think, working with the physical therapist after ACL surgery to first, number one, get their motion back, and then after that, they'll start getting their strength back. And typically the timeline after an ACL surgery is that they get their full motion back, usually within the first probably 3 to 6 weeks, and they're walking pretty normally on it by 3 to 6 weeks, and then they start jogging on it, usually around 3 months after surgery, running at about 4 months, jumping type, explosive type exercises at 5 months, and then back to sports types, activities and drills that are non-contact at 6 months, and then back to kind of full contact sports at usually around 8 months after surgery. And unfortunately, I think, obviously physical therapy and rehab helps them get back as soon as possible, but the biology of the ACL graft healing is one of the main limiting factors of why we have to kind of keep them out for so long, because the ACL just biologically takes that long to heal.
Yeah, I think that's the hardest part, especially for young athletes. They're like, man, I feel great right now. I feel like I could go out and pitch 6 innings just fine. And it's like, well, no, you can't, because like you said, you've got to take time for that ligament or that to heal, right? So
I got a question for you regarding post ACL surgery. I found that patients who are compliant in dealing with scar tissue and therapists who are treating scar tissue by far have less problems and better outcomes and a quicker turnover and returning back to their sport than those people who neglect dealing with their scars. People, they look at the surgery line and they think, well, that's all there is. Well, they had to cut down through layers of tissue that potentially can scar, whether it's the fascia, whether it's the muscle, the tendon. What would you say to athletes who are just, they want to get going? Compliance. How important is compliance in dealing with the scar, dealing with range of motion, and that kind of thing?
Right. That's a great point that you bring up. Like you mentioned, patients only see the scar, and with ACL surgeries these days, like we had talked about before, they're done arthroscopically, so there's very small incisions. But like you mentioned, that's just from the skin, but underneath there's a lot of work that's done with the soft tissue, the muscle, the tendon, the bone. And so that's why it's so important to be working on the motion pretty much immediately after surgery, so that the patient can prevent that scar tissue from forming. Because when they're working on moving the knee and working on getting the swelling down and getting their strength back, that helps. If the knee is just staying there stiff and not moving, that's where scar tissue can easily develop. But when the patient's working on the motion and working with physical therapy and doing even scar mobilization type therapy with the therapist, then that is what helps prevent the scar tissue from forming in the first place. And so I think the first 6 weeks after ACL surgery, or pretty much any knee surgery in general, is critical to helping to prevent that initial scar tissue from forming in the first place.
That's great.
yeah, I think that's huge. I think that's actually one thing I learned from you, Dad, up front. After I graduated, I actually got to work with him for almost the first year of practicing when we lived in Michigan still, my wife and I, and I've carried that through with this practice. And it's just big outcomes. Working on that scar is one of the biggest things to improve people's mobility, for sure.
I got another. Can I ask another question?
Yeah.
This is something that I've seen quite a bit, and I guarantee you that our listeners have either experienced it themselves or know somebody who's experienced this. I had a patient who came in for their initial evaluation. I did the evaluation, and it was very clear to me clinically that this person had a meniscal tear. And I contacted the PCP and said, I really think we need to get an MRI because I believe this patient has a meniscal tear, and it's most likely a significant meniscal tear, and most likely they're going to need surgery. But the insurance company would not allow them to get an MRI until after 6 weeks of physical therapy. And it was frustrating for me. It was frustrating for the patient. And I guarantee you it's frustrating for the doctor when they have to go in and do more of a repair than they would have done if they had gotten to them earlier. So my question to you is, and our audience wants to ask you this question, what can their doctor do to facilitate pressure the insurance companies to get moving on this so that they can get better outcomes? The doctor and the therapist are able to work with better tissues, if you will. And what can you do?
Right, that's a great point that you bring up. It can be very frustrating at times dealing with the insurance companies if they don't approve a procedure or approve certain imaging. And so, luckily, these days, I don't see it as often. For example, like you mentioned, for a patient that has what you suspect is a meniscus tear, that's a pretty bad meniscus tear. Oftentimes, when I see and evaluate a patient that I think has a pretty bad meniscus tear, then in my note that we send to the insurance company and to get approval for the MRI, we discuss the reasons for why we think they need this MRI much more quickly than before. For example, oftentimes with a big meniscus tear, there's a actual mechanical block in motion in the knee. They can't fully straighten it or they can't fully bend it. They feel painful clicking, catching, locking of the knee. And so if they have any of those things, I make sure to document those things and to make it known to the insurance company that this is what's going on and we need to get an MRI to look for a bad meniscus tear. And luckily, most of the time there's not any issues with that. But in the few instances where, like you mentioned, there has been an issue where they're saying that, well, we still have to wait 6 weeks to see if it's going to get better, when you as the physician know that it's not going to get better, then that's when I do what's called a peer-to-peer review, where I actually call a person at the insurance company. It's actually usually a physician at the insurance company, to basically, between the two of us, discuss why this needs to be done and the medical necessity of it. And thankfully, if it ever gets to that point, and I do that peer-to-peer review, they get it approved. And so, luckily, I think for me so far, I haven't had the issue where I really thought somebody needed this imaging because they had a major issue going on. And if it ever got to the point of the peer-to-peer review process, it finally got approved after that. And so far, I have not had an issue where it did not get approved after a peer-to-peer review process.
Excellent. Thank you.
Yeah, and I think that's probably one of the big benefits of dealing with a surgeon who's in private practice too.
Yeah, that's I think that's definitely correct, because we don't have to deal with some of the other kind of red tape associated with being in a big institution.
Right. Right.
I want to get back to, we were talking about shoulders a little earlier, and we're talking a lot about athletes, but we also have listeners who are having arthritic problems in their shoulder, and they have to get a shoulder replacement. Watching your video, there are two types of shoulder replacements, the standard anatomy and then the reverse total shoulder replacement. I used to, back in the day, years ago, when I saw the first shoulder replacements really coming out more on a regular basis, every time I saw them and that they were on my schedule, I'd cringe, because the outcomes were so bad. Poor mobility, poor range of motion, poor strength, poor functional usage of the shoulder. But over the past 5 to 8 years, it's like turned around like crazy. I get patients coming in, I'm thinking the mobility that these patients have now compared to what they used to have, and the outcomes that I'm able to get with these patients, and I'm talking about older patients who, I'm getting 120, 130, 135 degrees of flexion, and they're a shoulder replacement. What do you account that for? I mean, is it the procedure? Is it the appliance? What is it?
So your observations are definitely correct. Actually, this, I guess, goes back to one of the previous questions of what, procedures have made the most advancement in the past 10 years. And actually, I forgot to mention, shoulder replacement is, I think, probably one of the, procedures that has made one of the most advancements in the past 10 years. And the reasoning behind that is, first, the indications for the surgery are better now. So what I mean by that is that, like you mentioned, there's two kind of big different types of shoulder replacement. There's what's called an anatomic shoulder replacement, which means, if you think of the shoulder kind of like a ball in a socket, or a very shallow socket, but a ball in a very shallow socket, an anatomic shoulder replacement means that you replace that socket with a plastic socket, and then you replace the head ball with a metal head ball. And so it restores the native anatomy that the patient has, and that's called an anatomic replacement. And prior to probably 25 years ago, that was pretty much kind of the only type of shoulder replacement that was being done at that time. And the problem is that oftentimes these patients that get shoulder replacement, and they usually have shoulder arthritis, that's why they have the replacement, but they also have an issue with their rotator cuff. Like we talked about before, the rotator cuff is the group of muscles that help to move the shoulder and move your arm up and down and out and away. And so people would have the shoulder arthritis and get the anatomic shoulder replacement, but they would also oftentimes have a rotator cuff tear, and it could be a small tear or even a big tear. But the problem with that is that a regular anatomic shoulder replacement only addresses the shoulder arthritis and does not address that rotator cuff tear. And so if you put in a shoulder replacement in somebody that has a rotator cuff tear, in addition to the arthritis, their rotator cuff tear is not addressed, and so the rotator cuff is what they need to move that arm up. And so even if the shoulder replacement's done well, the rotator cuff's still not working, and so that's why there were such poor outcomes at that time, because the surgery did not address one of the other problems in the shoulder, and so some of the indications were not correct at that time. But luckily, in the past 10 to 20 years, a lot more work has been done in developing advancements in the surgical implants for what's called a reverse total shoulder replacement. And so it's called a reverse shoulder replacement because you actually change where the head ball and the socket are. So where the normal socket is, now you replace that with actually a big head ball, and then where the previous head ball was, you replace with the shallow socket. What that does is actually changes the biomechanics of the shoulder. And so and these are in patients that have shoulder arthritis and a rotator cuff tear. And so because their rotator cuff tear is not working, you need to get other muscles to work well in order for this shoulder replacement to work. And so what a reverse shoulder replacement does is it changes the biomechanics to allow other muscles around the shoulder to basically do what the rotator cuff was doing before, and specifically what's called your deltoid muscle, which is the big muscle on the outside part of the shoulder. And so with the increasing use of reverse shoulder replacements and better indications for just a regular anatomic shoulder replacements, patients are doing a lot better now and getting their motion back better. And also, like I said, of course, the implants are better now too. And so the implants last longer and the surgery can be done quicker and much more minimally invasive.
Excellent. Which one do you see most often?
It's actually, there has been a rapid increase in the past 10 years in reverse shoulder replacement, because pretty much most of these patients that have shoulder arthritis, which is the indication to a shoulder replacement, a large majority of them have rotator cuff problems or rotator cuff tear as well. And so in the past 10 years, there's been a significant increase in reverse shoulder replacement, and I believe there's actually more reverse shoulder replacements done now than a regular anatomic shoulder replacements. And so that's why you're seeing also a huge difference in some of these outcomes.
So I guarantee you that there will be someone out in our audience who's going to say, okay, my rotator cuff is fine. I've got arthritis, but my rotator cuff is fine. Should I opt for the anatomical? Will I get better outcomes with the anatomical because my rotator cuff is fine? Or should I get the reverse?
Well, luckily, we get imaging prior to surgery with an MRI and CT scan that helps to tell us if the rotator cuff is intact or not, because if the rotator cuff is intact and there's no issues with it, then I think they would do really well. If they just had arthritis of the shoulder, they would do really well with a regular anatomic shoulder replacement, and that's what I would recommend for them. But if the imaging that we got before surgery with the MRI and CT scan did show a rotator cuff tear, then I would absolutely recommend that the reverse shoulder replacement would allow them to have better function of the shoulder and allow the other muscles other than the rotator cuff to work to provide motion.
Thank you. Great.
Cool. So a lot of people, like you said, that are listening to this, we've got a wide range of audience as far as age. Like I said at the beginning, a lot of our listenership is CrossFitters, and a lot of CrossFitters are above the age of 40, 50, 60 years old. A lot of them do have arthritis. Like, it's a scary word. They're like, yeah, my doctor says I have arthritis. I'm just dealing with it, you know? If somebody was to opt for one of these shoulder replacements, what kind of outcomes as far as athletically and physically can they expect to get back into something like CrossFit? Is that something that would be a stretch, or?
That's a good question. Luckily there's a lot of research and advancements being done right now in terms of the implants to be able to try to prolong the longevity of the implants that are used in the shoulder replacement, and to be able to, withstand greater forces. At this time, unfortunately, my recommendation, if you get a shoulder replacement, whether it's a reverse or an anatomic, is, it's like it's a mechanical object. So it's like driving a car. The more miles you put on it, the faster it's going to wear away, and then the faster you're going to have to buy a new car. Same with any type of mechanical object, whether it's a shoulder replacement, hip replacement, or knee replacement. It's going to wear away over time, and the more you do on it, the more force you put through it, and the more you do on it, the quicker it's going to wear away. So not to say that you can't do these heavy physical activities, but the more you do, you're just going to put more miles on it, and so the quicker it's going to wear away, and the quicker you might need to have what's called a revision, or putting in another one. And then in this case, when you do a revision shoulder replacement, it's not going to be as good as the first one. It's like trading in your new car for a used car, and then every time after that, it's a worse and worse used car.
So traditionally, a lot of times with these replacements, we've been told that count on about 20 years. Is that still the case?
Typically, for there's a lot more data on hip and knee replacements because they've just been around longer, and they've been done longer. And the data on hip and knee replacements is probably around 20-25 years or so. And then for shoulder replacements right now, about probably 10 to 15 years. But again, there's a lot of advancements being made in both shoulder, hip, and knee replacement in terms of the materials being used and the implants that are being used, and how they're being manufactured to try to prolong the longevity of it. So my guess would be that it would only continue to kind of get better over time in terms of how long they last.
I got a question, sort of changing the topic a little bit. Apogee Therapy Center, we are a functional medicine integrative health-based facility. And what that means for the listeners is that we look at the total body, including what things need to be done to make that body better, whether it's functional training, whether it's nutrition, sleep, even cognition. How are you relating to your injury? All these things impact your ability to recover. So as a physician, how do you talk to your patients about nutrition? How important do you believe that nutrition component is? We have a nutrition dietitian on our staff. She's licensed in the state of South Carolina. She lives in Michigan. We can do telehealth. And so my question is, how important do you think nutrition is in the recovery process after surgery?
Yeah, that's a great question. I do think it's extremely important, and to be honest with you, I think that's something that I need to get better at in terms of learning more about it. I'm definitely no expert in nutrition right now, but I do agree with you that it is extremely important to be aware of, and it's one aspect of recovery and healing or training, and it's something that I need to read more about, learn more about, but until then, I'm definitely going to be sending it to people like you who are more experts in it than me.
Well, that's great. I tell my patients, if you want to build a brick house, you need bricks. And if I want my tendons to repair, I need collagen. I need magnesium. I need vitamin D. I need zinc. There's all these different substrates that are important in the healing process. And so we spend a lot of time talking to our patients about this, and I really believe our outcomes are better as a result. And that's why I wanted to ask you that question, because I deal with a lot of physicians. We've had, I believe the last I checked, 785 different doctors who have referred to us up in Michigan. And so we're pretty broad based in all the people that we are seeing. And I'm finding out and talking to the physicians, I hear the same thing that you're saying. You guys are great at doing the surgeries. You're great at giving the medications which are appropriate, but you don't get a lot of training in school regarding nutrition and the importance thereof. Would you say that's accurate?
I think that's very accurate. You're right. So, during our training, we learn a lot about the medicine, about the, surgery, the surgical technique, and yeah, we have very minimal training in things like nutrition, and so I think that it would be something on a wide scale that could be improved, and in terms of physicians taking care of every aspect of the patient rather than just certain specific aspects. And so I'm a victim of some of that, and so that's something that I do agree should be improved upon.
Yeah, I think we had a physician on a couple months ago, and Dr. Kornweiss, and we kind of touched on this as well. And he brought up the good point that there is so much to learn in medical school, and the curriculum is so difficult, and like I just said, there's so much to learn that incorporating something like nutrition, it's almost better to have what we have, dietitians, nutritionists who are experts in that area, for these physicians to refer to. I think it's on us to educate to the physicians too. Hey, these people are available. Send them our way. It's going to help outcomes. It's going to help progress their rehabilitation. It's going to help their sleep. If people are sleeping better, they're going to heal better, right? Because if you're not sleeping, you're not healing. That's when the body heals. So all of it is just like one big, what I would call, circle of life.
Exactly. One of the things I've told my patients so many times over the years, you don't want me cutting on you, okay? You don't want me prescribing the medications. That's not my area of expertise. But if we can assist the physician to get better outcomes by giving them the things that we are experts in, it helps us as a team to make it work. It doesn't mean that the physicians aren't good. They're great at what they do, but they also they have a component to the process, a very vital component. But what we do and what we can bring to the table can be very, very beneficial in helping those physicians to get the outcomes that they want, and ultimately that you get back to where you want to be.
I think it's interesting that you kind of hit on the mental aspect of the rehab part as well, because I feel like, I've made it very public that I went through a huge surgery myself, and that part was probably even harder than the actual physical part, the mental part of it. Is that something that you find a lot with your patients? People just maybe having to, maybe referring them out to a psychiatrist or a psychologist, or prescribing some psych medication?
Right. Luckily, haven't had too many of those, but you're correct. If, there is definitely a mental and psychological component to, for example, after an ACL surgery, every athlete remembers how they tore their ACL, and they don't ever want that to happen again. And so that's always in the back of their minds. And for some athletes, they get very hesitant about getting back to playing or doing certain things, and that stays on their mind. And so in those instances, I think it is important to work with somebody about that who has expertise in it. Again, I don't have expertise in that, but I am happy to get them to somebody who does. And, there are sports psychologists who can work with athletes or patients on kind of getting them back in after a significant injury. Or even, physical therapists do a really good job with that too. And so I think it's just important to, like you said, not only to treat the physical aspect of things, but also to remember that there's a mental component to it as well.
What about steroids? I mean, there's been a lot of use of steroids, abuse of steroids throughout the years in sports, and everybody wants to be able to, be at their optimum performance level. And clearly, we've seen the overuse of steroids in the professional ranks in football, where people have become very aggressive and they've ended up in jail or committing suicide. What would you say to our athletes out there regarding steroid usage? And I'll just leave it at that.
And I wouldn't even just keep it at steroids. I would also incorporate performance-enhancing drugs like SARMs. We're seeing that big time in some of these supplement industries, that
Right.
especially in the fitness industry.
Yeah, I'm just like you guys, obviously not a big fan of steroids and performance-enhancing drugs. I think the athletes who do use it are just pretty much, mostly think about the short-term gains of using these. But using steroids and other performance-enhancing drugs have some pretty major long-term implications that can cause, pretty bad long-term effects, both from a medical standpoint. For example, steroid use can actually cause significant heart issues and what's called cardiomyopathy, which is just a heart condition where the heart is no longer functioning like it should. It can cause other organ issues later on in life. And then what I see most commonly as an orthopedic surgeon from steroid use is actually steroid use significantly increases the rate of tendon ruptures. And so, for example, triceps tendon tears are pretty much non-existent in people that don't use steroids, but triceps tendon tears is a common tendon injury seen in people that have been using steroids for a long time. And there are other tendon tears, it can weaken the tendons and cause these tendon ruptures. And so that's what I commonly see as an orthopedic surgeon with steroid use, is these tendon ruptures that unfortunately don't heal on their own and need surgery to be fixed.
Now, sometimes patients have a confusion and athletes have confusions regarding performance-enhancing steroids and stuff like dexamethasone sodium phosphate, which would be an anti-inflammatory. Is there any fear of using anti-inflammatory steroids for the short term to help them get through their initial phase in the recovery? Should they worry about that at all?
Right. That's very important that you brought up. Yes, there is a significant difference between the performance-enhancing steroids versus the steroids that physicians prescribe that are anti-inflammatory steroids. Things like you mentioned, dexamethasone or prednisone or methylprednisolone. Actually, in my practice, I will oftentimes, if somebody is coming in with a lot of pain and inflammation, I will prescribe them a short course of an oral steroid for about a week. That helps a lot with their pain and inflammation, just to get everything to kind of calm down some. But you are correct. You don't want, even for the oral steroids that are prescribed by a physician that are the anti-inflammatory ones, it's not good to be on those for a very prolonged period of time, for months to years at a time, because those can cause significant chronic side effects as well, with weakening of the bones and also, organ effects as well. And so I typically don't prescribe any oral steroid, anti-inflammatory steroid, for longer than a week or so at a time. But there are patients that these are patients that I usually don't see, but patients that usually are seeing like a rheumatologist that have either autoimmune diseases or other type of chronic diseases that need chronic steroids for prolonged use of time to help with their chronic autoimmune disease.
What about I'm sorry, go ahead.
I was going to ask, how often is too often to receive a cortisone shot, in your opinion?
Yeah, my recommendation typically for a cortisone injection is a maximum of 4 in a year. So that means minimum of 3 months in between. And the thing with getting cortisone shots is that they help a lot with the pain and the inflammation, but unfortunately it doesn't actually cure the underlying problem. So it's it provides great pain relief, but it's not going to cure the issue. And so for many people, it provides kind of a bridge towards a more permanent solution.
So you would encourage the patient once they get that cortisone injection, oh, you're going to feel better, but you need to get into physical therapy. You need
Right.
to work on that training and
Exactly.
strengthen up those tissues.
Right, because the cortisone injection can get their pain down to a tolerable level, and then at that point, they're able to do the physical therapy or whatever other treatment that's needed to basically strengthen the muscles to help offload the area that's painful, and that is what prevents the pain from coming back.
Two different areas with injections, the Achilles and epicondylitis. One of the things that I've seen is people rupturing. You had mentioned that earlier, but even with 2, maybe even 3 injections, it could be bad enough to cause that. What do you say to those athletes who have an Achilles tendon issue and want to get this cortisone injection in the Achilles?
Yeah, for Achilles tendon, I never recommend cortisone injection into the Achilles. And so in terms of what injections could potentially help with, so obviously, I would usually always start with physical therapy, because the vast majority of people with Achilles issues, 80 to 90%, will get better with the physical therapy, with the stretching and strengthening program. But for those that continue to have issues, then one injection that is being studied a lot right now is something called a PRP injection, or platelet-rich plasma. That's where you actually take a portion of the patient's own blood, and then it's spun down in a centrifuge, and then the top portion of that is the layer called the platelet-rich plasma. It has all of your platelets in it, which is theoretically provides healing benefits. And so there are a lot of studies being done on PRP injections, not only in the Achilles tendon, but everywhere in the body, in the knee and the shoulder. But luckily, in the Achilles tendon, has started to show some favorable outcomes. And so if that's something that is still bothering somebody despite an exhaustive treatment of physical therapy and time, then it would be reasonable, I think, to consider a PRP injection in the Achilles. It's just that, unfortunately, at this time, it's not covered by insurance, and so people have to pay out of pocket for that.
What about stem cell? I had both my knees injected with stem cells. My right ankle that I had surgery on years ago, and I had fractured it back when I was in high school, and I got so incredibly better by getting the stem cell injections. What's your thought on that?
I'm glad you felt better. Similar to PRP, stem cell injections are a super hot topic right now in sports medicine and orthopedics, and there's a lot of research being done on it. The current medical literature doesn't have any definitive evidence to say that it significantly helps, but there are a lot of studies that show that it helps, but some studies that show that it doesn't help right now. And so that's why right now it's not FDA approved and not approved by insurance. But again, I don't think it causes any harm right now. So if that's something that somebody's interested in, if it could potentially provide benefit, but obviously, again, patients would have to pay out of pocket to get it. But I think with the research coming in the next 5 to 10 years on it, I think it would definitely start becoming an option if it starts becoming proven to start working effectively in most patients.
Great, thank you. I want to go back to the other topic, because there's one other thing I really did want to ask you, and the idea of hormones, testosterone, estrogen. Now, I know you're not an endocrinologist, but still, it's important to our listeners because there's such a focus on increasing testosterone and muscle development. How do you feel about that? And as a therapist, it's something that has really been on my heart and my mind with patients over the last several years.
Yeah, like you mentioned, I'm not an expert on that, but typically I don't think it's a good idea to mess with the hormones unless there's a medical indication for that, which would obviously best be treated by an endocrinologist. But in terms of using those hormones for in terms of sports performance or development that's not prescribed or indicated by a physician, I think is not a great idea at all, and could, like similar to the steroids and performance enhancing drugs, people see the short term effects of it, but they don't think about what long term effects that it could cause that could be pretty substantial and detrimental.
Yeah, I agree. I think, I've talked to this about my patients, and it goes back to the nutrition, it goes back to the sleep, it goes back to the training that you're doing. Obviously, after an injury, if you went to your doctor and got blood work done, your T-score might be a little bit lower than it normally is. But the way we like to, if we can even it out with nutrition and sleep, that's obviously going to help improve your healing a lot quicker, because when your body's functioning at what its normal is, that's a good thing. So finding out what your normal is and getting blood work every year, I think, is important for patients.
Right. I would strongly encourage people to have an annual physical and go to a physician who's going to give you not just your standard blood screen, but to look at your free T, your T4, all your resting insulin levels, your A1C. All these things are going to be a big indicator of your actual health. And so anyway, not that I'm playing physician, because I'm not doing that, but I agree. It's so important to look at the big picture and not just look at one element such as testosterone. You have to look at how this all is working as a whole in your blood system.
Mm-hmm. For sure. Yep. I think it's also important not to compare your blood work to others, because what's your normal is your normal. So I think people need to get past that too. All right. Dude, let's talk about your life, man. So what kind of stuff do you like to do outside of work?
Yeah, I mean, we already talked about, enjoying playing sports, but outside of sports, right now it's my wife and I. We don't have any kids yet. We're probably going to have kids in the next few years, but we enjoy actually traveling a lot. And so we usually try to do, one, maybe two big trips a year to try to go to a different country, explore a different culture, and we enjoy eating different types of food. And so I think, that's unfortunately something that COVID has really put a dent in this past year and a half, but hopefully we can get that back going once we can get over this COVID issue.
Yeah, for sure. And another question I have for you is what kind of stuff do you like to do for fitness?
Yeah, I used to do a lot more weightlifting when I was in college. Unfortunately, my physique no longer represents that, but right now mostly I just focus on cardio, and I try to get on the Peloton bike to do cardio. But there's definitely more that I should be spending on doing cardio and weight training right now. But maybe I'll have to get some advice from you on that.
Yeah, for sure. Those Peloton bikes are no joke, though, man. They are all the rage right now, and I can see why, because you're literally, it sounds like you can compete with so many. You get your buddies. There's like this board, the scoreboard, basically, and you guys can compete every night in a race, and it can be a different type of terrain every single night. So I can definitely see how that could get addicting. But yeah, it's cool, man. I first met Dr. Gao at a CrossFit competition, actually, at Fittest of the Upstate. Shout out to Gordon and Annie Lake, Fittest of the Upstate. They were conveniently sponsors, and their tent was conveniently put right next to ours. We were also sponsors at that event, and I got to meet Dr. Gao for the first time in this awesome Hawaiian shirt, and I knew from then that he would probably never forget the crazy-looking guy at the CrossFit competition.
Never.
But no, dude, it's been fun getting to know you more over the last couple months. Dad, what do you think about doing some rapid-fire questions?
All right, I got the first one.
All right, go for it.
All right, you talked about liking to travel.
Yeah.
You've got 4 choices.
Okay.
You go to the south of France, Singapore, a Mediterranean cruise, or the front row seat at a Clemson football game during the national title game? What are you choosing?
Oh my God, that is a tough one. Well, what I'll say to that, and this is maybe a cop-out answer, but luckily Clemson's been doing so well recently that I think I will have more opportunities to do Clemson national championships. But I have always wanted to do a Mediterranean cruise. And I think once probably we have kids, that might be a little bit more difficult to do. So I'm going to pick the Mediterranean cruise right now and then go to some future Clemson national championships front row.
There you go.
I agree. Dabo's gonna have to step up his game. They lost to NC State last week, and they've got Boston
it's
College.
not happening this year.
Yeah,
but
definitely not this year.
Yeah, it's not happening this year, no.
But no, the college football landscape is very interesting this year to me.
Go blue.
Yeah, for sure. Ian, if you were to go out to eat tonight, downtown Greenville, what restaurant are you taking your wife?
Downtown Greenville, she loves Gianna.
Ah, yeah, that's a great
So,
place.
For those who don't know, it's a kind of modern Italian restaurant with, very kind of modern vibe and good food and a great atmosphere. And it's kind of on the second floor of a building that's overlooking the Falls Reedy Park. And so it's a pretty great date spot. And she loves the food there. So
Yeah, and you can go right downstairs and get some Lulu.
exactly. Yeah.
All right, you're up.
All right, so you have the choice to be the best in the world at something. Would it be the best singer in the world, the best musician in the world, the best athlete in a particular sport in the world, or the best business person in the world?
That is a great question. It would be a toss-up between the best athlete or best business person. Currently my job kind of is involved with both business and athletes. Not that I'm an athlete myself, but dealing with sports and athletes. But I think just growing up, the dreams of being a professional athlete, I would have to probably go with being the best athlete in a sport. As the answer.
All right, cool. If you could pick one thing for your future kids to be really good at or really love to do, what would it be?
Really good at
And love to do.
and love to do.
There's things that we're good at that we don't love to do.
Well, I would hope that what they love to do would also be able to be probably their career. So, I wouldn't mind if it again, being around sports and so long, if they love to do sports and are good at it and they could make a career out of it, that would be great.
Do you have a favorite sport?
My favorite sport is basketball.
Okay.
So that's what I still, enjoy playing. And fortunately, when I was in undergraduate at Duke, I was able to, follow the basketball team there and did, all the camping out for the games.
Oh,
And
that's awesome.
luckily, my senior year there was one of the national championship years, and so I was able to go to the Final Four. And I was at this was in Indianapolis in Lucas Oil Stadium, and that was the year I was there at that national championship game, and that's like the highlight of my sports watching career.
No, that's awesome. Yeah.
All right, where would you rather be? Cross country skiing in the most beautiful landscape you could ever imagine? Up in a deer blind with the biggest buck with the biggest antlers possible right in your sights. Okay?
Oh, man.
In a boat race on Long Island Sound, coming downwind with all the spinnakers going, and you're in the lead.
That's a lot of
Or-
options.
Such
Or
visual imagery.
Or would you rather be at a basketball game rooting on your favorite team?
Well, I think you would know the answer to that, but to give the reason as to why not the other three, the last time I went skiing or snowboarding, I broke my thumb. Or actually, that was the first time. The second time I had a AC joint separation.
Oh no.
So I would probably avoid that for now. I have never gone hunting in my life, so that would be the first time. Not to say that I wouldn't enjoy it, but I don't know if I would be good at that second choice. And then I'm also not a sailor, so if somebody else was driving or was steering that boat, I would enjoy the ride, but I don't know if I would appreciate it like somebody else would. So it would definitely be the basketball game for my favorite team.
Excellent.
All right, cool. I think that's good. I think that's a wrap. Are there any last things you want to say, Dad, before we get off?
I've really thoroughly enjoyed doing this. This is the first time I was ever a host on a podcast. I was a guest on a podcast earlier this year, and that was the first time I ever did that too. But I thoroughly enjoyed getting to know you. I respect you a lot. And I think David is really, shall I say, blessed having you as a friend and as a surgeon that he can rely on if he needs to send a patient to. So I'm just encouraged to see what David's doing with his podcast and the variety of people that he has had on there. And it's been a great time. I've really enjoyed it. Thank you very much for inviting me.
Awesome.
Well, thank you very much for having me and for the very kind words. And definitely can't tell that this was your first podcast hosting. You're a natural at it. But yeah, thanks for having me here, and it was great to be a part of this.
Yeah, talking has never been a downfall for my dad, that's for sure. There has been many nights where we have stayed up very late, and he has said lots of words, and I have said few. But no, Dad, for real, it's been awesome having you on here. I know that you are an avid listener of the podcast and a big supporter.
I am.
A big supporter of the podcast, and not just Apogee, fitness podcast, but also, with Apogee Therapy Center, and then obviously supporting me my whole life and getting to me, helping me get to this point in my life has been huge. So I know I don't say thank you enough. So thank you for everything you've done for me. I think,
You're welcome.
And then obviously, Ian, it's been great. Like I said, getting to know you the last couple months. It's very refreshing to hear a surgeon talk about surgery the way you do. You explain it very well. I think that everybody listening to this podcast with a medical background or without a medical background will be able to understand and kind of relate to the surgical procedures that you were talking about. So I thought you did an awesome job. Excited to see more of your patients. I'm excited to send more of our patients to you guys, and really excited for everything Kona has going on. So with that, I will end it here.
One more thing.
One more thing.
I want to tell all of the listeners how proud I am of David. He's been amazing. He's a great son, great father of his children, and a great husband. And I'm very, very proud of you, David. You're doing an absolutely amazing job.
Well, thank you. I had a good person to learn it all from. All right. Well, after that, we're going to wrap it up. Y'all heard it here on the Apogee Fitness Podcast.